Okay, welcome back. Can anyone or everyone hear me? Good, I think we're back here. Okay, so I hope everyone had a productive morning, somewhat edible lunch, and we're ready for some more learning. So on that notion, I'm going to have Dr. Michelle Klaiman come up, and she's from St. Mike's, and she's going to give us a little talk. She's both an emergentologist and an addiction medicine specialist. There's your clicker. Welcome.
Thank you so much for having me. Wow, it's so nice to be back in person. This is the first talk I've given in 2 years in person, so it's really nice to see all your faces and not my own in the corner. So thanks so much. I'm really honored to be invited to talk about anti-craving medications for alcohol. It is a topic that I don't think gets enough screen time in eMERGE teaching, and so I hope that you guys are going to leave with some clinical pearls today that you can use on your next emergency shift. So I'm going to start by way of a case that you've probably seen 100 times. A 45-year-old female is brought into the emergency department by EMS. She was found intoxicated on a bench and passed out, and a bystander called 911. Some of you have all seen some variation of this story, right? Almost every shift I see multiple patients. I do work at St. Mike's downtown, but I'm sure that no matter where you practice, rural, community, academic center, you're going to see these patients. So you go over, you pick up the chart, 45-year-old female. You go over, you examine her. You give her a strong sternal rub. She sort of moans. She says, oh, I drank too much. She puts the blanket over her head, rolls over. You give her a once over. She's moving all of her limbs. There doesn't seem to be any signs of trauma. Her vital signs are normal. So you figure that she's fine, and you move on to go see the other 20 patients that are waiting in your waiting room. So 4 hours later, your nurse calls you, and they say, that patient that you saw, the 45-year-old female who was intoxicated, well, she's awake now and she wants to go. Is that okay? And so how many people would say, yes, send her on her way? Yeah? Right, maybe you have an addiction worker in your department, and you'll have them come and talk to her to screen her for an alcohol use disorder. Maybe you have a peer worker or a social worker. Maybe you'll go over yourself and chat with the patient. Maybe you'll screen for an alcohol use disorder, do a brief intervention as you've learned and refer her to treatment, or maybe you'll print off a resource or two that you might have in your community. We have this on our EMR, so there's an option to click this order DC home when awake, alert, and ambulating safely. And so I think a lot of our patients actually do get discharged without the physician talking to them, right? And I'm sure that happens in your center as well. But I really see this as a missed opportunity. Even if you do all of that, you do SBIRT, you chat with the patient, you give her some resources, what you haven't done is chat with her about anti-craving medications. Now, that is what I'm really here to talk about. Anti-craving medications are very effective and they're safe. And alcohol use disorder is a huge problem. It is pervasive across all walks of life and across the entire country. And we know that during the pandemic, the problem has only gotten worse. So there's been an increase in hospitalizations and emergency department visits for alcohol intoxication, alcohol withdrawal, and then there's also data out of the state showing that deaths have increased by 25% related to alcohol during the pandemic. And these trends are in all age groups, and actually most notably between the ages of 33 to 44. And that statistic really struck me because it's a very young age group to be dying from alcohol, and a big increase during the pandemic. Women, in particular, are incredibly sensitive to the harmful effects of alcohol. We know that women experience hepatic injury and negative effects to their coronaries, and we're also at risk for cancers directly related to alcohol. And I was really struck by the stat that 1 in 3 cases of breast cancer, in part, could have been prevented if somebody did not drink alcohol. So we're really putting ourselves at risk when we consume alcohol. And there has been a huge increase in the rates of alcohol use disorder and alcohol intake during the pandemic. And actually, the rates now of alcohol use disorder in women exceed those that we are seeing in men. And there is some data out of the state showing that there has been a 41% increase in heavy drinking days in women during the COVID pandemic. So the COVID pandemic has really affected women in particular. That in combination of advertising targeting women. I mean, we've all heard about mommy juice, right? That glass is mommy juice, the huge wine glass. And when you have wines that say mommy's time out or the mad housewife, you can see how it really does affect women starting at a very young age. Looking a little bit more locally at data out of Toronto, there was a recent study published out of UHN done by Jennifer Hume and colleagues. And what they looked at was 25,000 patients who had visited the emergency department at least twice within a year for alcohol-related issues, so behavioral and medical problems related to alcohol. And then they looked at the mortality data. And their results were fairly shocking. What they found is that the overall mortality for anybody who had presented to the emergency department with a reason related to alcohol was 5.4% if they had 2 visits. It was 4.7%. So the overall mortality, 5.4, and then 2 visits, 4.7. And if they'd had more than 5 visits to the emergency departments in the past year, their overall mortality was 8.8%. And that's quite an increase. So from 2 visits to 5 visits, that was a 38% increase. And just think about all the people you see in your emergency department who come into the department more than 5 times per year. We have frequent flyers in our emerge, and we see them once a week. So they're a huge risk of death. Despite these huge numbers, despite the negative effects of alcohol on society, less than 9% of patients receive an anti-craving medication for their alcohol use disorder. These medications are safe and they are very effective, and there's no reason why we cannot be prescribing these out of the emergency department and talking to our patients about it. The emerge is usually the only point of contact a lot of people might have with the healthcare system. And a lot of family physicians, unfortunately, are unaware of anti-craving medications. So we're in a really good position to prescribe a medication that can make lasting change. So let's say you go back to see the patient. You tell the nurse, please don't discharge her. I'm going to come back and chat with her. And you start to have a conversation. You explore her alcohol use, and she tells you that she's been binge drinking alcohol for the past several years. She consumes about 1.5 liters of wine for 5 days in a row, and then stops, and this pattern repeats every 2 weeks. She's gone to AA, she's gone to counseling, but really it hasn't helped, and the COVID pandemic's only made it worse because she's now working from home. So you ask her, has anybody ever talked to you about an anti-craving medication? I noticed you've been to the emerge a few times. Has anybody ever talked to you about these medications that can help? And she kind of looks at you blankly, and nobody's ever mentioned this before. And this happens all the time where you have people who've been in contact with the healthcare system and have never heard of these medications. So anti-craving medications for alcohol are very helpful. I mean, they're not magic pills. Just starting these medications are not going to stop somebody drinking, but when they're combined with psychosocial interventions, with counseling, with group therapy, they can be just what a patient needs to make change. So we know that anti-craving medications reduce drinking, it reduces emergency department visits, admissions, and overall healthcare costs. There's a lot of data showing that they're quite effective. The medication that you need to know is naltrexone. So there are 2 first-line medications for alcohol use disorder, and the number 1 is naltrexone. So it's kind of interesting, right? Naltrexone is the oral form of naloxone, right? So it's an opioid antagonist, so that's kind of interesting. And the mechanism is very interesting. It all relates back to dopamine. So just as a reminder, neurophysiology and the pathway of addiction, when we do pleasurable things in our life, when we have a good meal, when we make connections with other people, when we are intimate with our partners, it releases dopamine, right? And that dopamine causes reward, that feeling of pleasure, and that drives our survival behavior. When somebody consumes alcohol or other drugs, opiates, whatever, there's a huge surge of dopamine. And eventually, the dopamine that's released from continuous alcohol or drug use kind of hijacks the usual dopaminergic reward system, and then seeking that behavior becomes more important than all of our other survival things. So that's why it's very hard for people to stop, and that's what causes their cravings, is this dopamine. You're always looking for that dopamine surge, and all those other things like connecting with friends, eating a good meal, those become less important, and the alcohol and drugs overtake the life. And so this is the pathway. So we have alcohol at the top. When somebody consumes alcohol, they get a release of endogenous opiates. So we're not taking an opioid, but we have opioids within our body that are released when we think about alcohol or when we consume alcohol. Those endogenous opiates attach to the mu opioid receptor. There is this big dopamine surge, which causes reward, and then that drives the cravings, and it's just this vicious cycle. And what naltrexone does, because it's an opioid antagonist, it blocks the endogenous opiates from binding to the mu opioid receptor, and it is specific to alcohol. It's just a very interesting mechanism. Because of this, however, naltrexone would be contraindicated in somebody who's taking an opiate or who's using opioids, because it would block their exogenous opiates if they were to take that medication. Okay, so that is one of the contraindications for naltrexone. The dose, fairly easy to remember, 50 milligrams once a day. And some people do start at 25 milligrams for the first 5 days, although I haven't really found any literature to support that. And then in the States, they actually do go up to 100 milligrams. I do have a couple patients who are on 100 milligrams as well, but in general, the dose that you need to remember is 50 milligrams once a day. There is a limited use code for those who work in Ontario. So for patients who are in ODB or ODSP, you have to write the limited use code 532. Otherwise, the prescription is going to be sent back to the emergency department, and the pharmacist is going to ask for that. The indication is simply alcohol use disorder. Naltrexone has a very good number needed to treat. So there is a number needed to treat at 12 to return to heavy drinking, and 20 prevents any drinking. And those are actually pretty good number needed to treat, because we think about other medications. Usually a number needed to treat between 20 and 50 would be considered acceptable in the medical literature. So naltrexone is very good. Another contraindication for it, though, is if the liver enzymes are 3 times the upper limits of normal. So somebody has known alcoholic hepatitis, then naltrexone would not be your first choice. But you don't have to do the LFTs and the emerge. It can be checked after 4 weeks by the family physician. You don't have to do that. Let's say somebody, though, has known alcoholic hepatitis. What do you do then? Well, luckily, we do have another medication. This is also considered first line. It's called Acamprosate. The name brand is Campral. And this is a medication that the mechanism of action is poorly understood, but it's thought to restore the balance between excitatory glutamate and inhibitory GABA. And that balance is disrupted through chronic alcohol use. The dose is 666 milligrams TID, and this is why for me it's not my first choice, because it has to be taken 3 times a day, so compliance is an issue. Also has a limited use code, and the number needed to treat is very good, also 12 and 9. So these are based on systematic reviews and a Cochrane review of over 7,000 patients. So these are quite effective medications. What if your patient tells you that she's pregnant? So naltrexone and acamprosate are both category C. And what that means is that in animal studies, there is some evidence of possible harm. So with naltrexone, you're talking about early fetal loss and increased birth rates, and with acamprosate, cleft palate, although that was only shown in 1 study and not seen in subsequent studies. But there are some other options. So ondansetron has also been shown to be effective. So the shared decision-making is really key here if you do have a patient who's pregnant who you're talking about anti-craving medications. Although they're category C, but a colleague of mine often says, alcohol is category X, so maybe category C isn't so bad. And there is some emerging evidence that naltrexone is actually safe in pregnancy. There was a study recently published around its use in opiate use disorder, and there's been no adverse effects to the mom or to the fetus. You might want to talk to an addiction specialist in this case, maybe not start the anti-craving medication if you're not aware of the nuances around these medications. And we do have a couple pregnancy programs in Toronto. There's one at St. Joseph's Hospital, Teacup, and there's also one at St. Michael's Hospital. So just know your local resources and where you can refer these patients. Now, you may have heard of a couple other medications used for anti-craving medications, topiramate and gabapentin. Topiramate, there's some evidence in concurrent stimulant use disorder. The only issue is that there's some sedation associated with it in the morning, so sometimes people stop it because of that. Gabapentin is also a pretty good anti-craving medication. We often use it for alcohol withdrawal. So at a dose of 300 to 400 milligrams TID for a week, it usually reduces the amount of diazepam somebody needs to take, and then often patients continue on it past their subacute withdrawal phase and use it as an anti-craving medication in combination with naltrexone or acamprosate. There is some street value to gabapentin. There is some potential for abuse, so cautious prescribing here is important. The reason that it works probably has something to do with the anti-anxiety effect. as well as its effect on sleep, so it can help with insomnia. So you might see these medications being prescribed. And I can't give a talk about anti-craving medications without talking about disulfiram, because I always get questions about disulfiram, known as antabuse. This is actually a very old medication, initially available in the 1950s. It's not available in Canada anymore. So if a patient is asking for antabuse, they have to go to a compounding pharmacy, and it's not covered by the provincial drug plan, so they would need private coverage or they'd have to pay out of pocket, and it is quite expensive. The way that it works, just to remind you, is that it inhibits aldehyde dehydrogenase, and then they get this big buildup of acetaldehyde, and that causes patients to have a very negative reaction, like a really bad hangover or withdrawal symptoms about 10 minutes after consuming alcohol. So they can get very, very sick. And so it's a negative reinforcement strategy, and that's why it's not very effective. People stop taking it, compliance is an issue, and it can't be used in certain populations, especially those with coronary artery disease, because that reaction can be quite dramatic and people can get quite sick. So sort of fallen out of favor, disulfiram. The only time I've ever prescribed it is on a patient who is already stable on naltrexone and was traveling overseas to go to a wedding, and they felt like they needed that deterrent when they went. So that was the only time I've ever prescribed it, but I don't think you will be seeing this very much in the emergency department. So out of those 6 medications, naltrexone, acamprosate, disulfiram, gabapentin, topiramate, and ondansetron, the 2 that I really want you to remember are naltrexone and acamprosate. So you're going to take one thing home from today, naltrexone and acamprosate. For those of you who are more interested in this, there's lots of resources out there. One resource that I particularly like is the Medify website. So Medify stands for Mentoring, Education, and Clinical Tools for Addiction. And this started as a pilot project at a women's college hospital by Malkahan and is now a provincially funded organization. And their goal is to provide exactly this, so education to healthcare providers, including emergency physicians, on how we can better our treatment of patients with alcohol use disorder and addictions within the emergency department. So I encourage you to go into that website. They have lots of provider resources. This is the landing page. And you can see that there is a green button highlighted on the side for ED resources. And in that you can find mostly resources related to opiates, but there are some patient information sheets around alcohol. And when we're thinking about what we do with this patient after we discharge them, so you've written them a prescription for naltrexone, where do they go next? You really need to know your local resources. So do you have a RAM clinic in your community? Is there a family physician who could prescribe this? You could go into this website, the Medify website, and where my red arrow is pointing to the RAM clinics. You can click on this, and it's going to show you all the RAM clinics in Ontario. And RAM stands for Rapid Access Clinic to Addiction Medicine. And these are meant to be low barrier clinics where patients can just show up without a referral, without an appointment, and can get treatment for their substance use or alcohol use disorder. So it's a great resource to have. Go on the website, take a look at what sort of resources are available to you. So take-home points, just offer anti-craving medications to your patients, right? Now you know about them, you have no excuse. You know, so you might hear, you know, these medications, maybe they're not our wheelhouse. We should leave this to family doctors. We should leave this to addiction medicine specialists. But I think that it is in your wheelhouse. And I think that we are really in a position to at least talk to our patients about anti-craving medications. Let them know that there is something out there that can help them. And if they don't want to start it, then fine. At least now you've planted this seed. And now you're aware of it. So thank you very much for listening. And I hope that the next time you see somebody who you think might have an alcohol use disorder, you talk to them about anti-craving medications and write that script. Thank you.
Thank you very much, Michelle. Let's say, hypothetically, you had 3 boys, college age, names maybe Jordan and Adam Ryan, and you wanted to slip them one drug to decrease their cravings for weekend binge. It would be naltrexone, right?
Naltrexone.
Not that,
yeah.
Totally hypothetical. We're gonna have some questions.
Questions at the end or questions now?
I think we're gonna we can do
one
one
or two questions.
All right,
Yeah.
sure.
Can anyone hear me? Yes, excellent. We have a bunch of questions, great questions from the virtual feed. Naltrexone, 50 milligrams once a day. What's a safe amount to give from the emergency department? And then typically, how long are they on it for?
So it's a great question. So naltrexone, it's a very, very safe medication, right? As long as they're not taking an opiate and they don't have alcoholic hepatitis, it is safe to prescribe. I'd say 4 weeks is a reasonable amount of time. It all kind of depends on your follow-up. If you're in a community where you have an addiction clinic where they can go the next day, then you could prescribe them a week, right? Give them a bit of time to decide whether or not they're going to take that step to go to the clinic. But I don't think 4 weeks is unreasonable. And usually it's at that 4 weeks mark that we want to check the LFTs anyways. So in a patient who you're concerned about, they do want to get some sort of follow-up at the 4 week mark, so 4 weeks I'd say. And patients, and how long they need to be on it, patients often stay on these medications for as long as they need. So anywhere from 6 to 12 months, because that allows them to kind of participate in the counseling and participate in the psychosocial supports that they might require to help. So usually patients stay on for 6 to 12 months or longer, many years.
Excellent. And closely related to alcohol use disorder is benzodiazepine use disorder. Can naltrexone be something that's reasonable to give from the emergency department and someone with benzodiazepine use disorder?
I haven't used it in benzodiazepine use disorder, and I don't know if there is any evidence for that.
Okay. Thanks very much, Michelle.
Thank you.
All right, now we're going to thank you very much. That was very useful.